respected chairs, my fellow presenters, gurus, my colleagues, and most importantly, very young, energetic scientists, researchers in health and population sector. Jadau, namaskar, a very warm welcome and good morning to you all. आउँदै गरेको नव वर्षको शुभकामना सहित म यहाँहरुसँग next 20 minutes I will be with you. I'll be switching in between Nepali and English. I will be talking in between. The topic of today I've chosen is from the disparity to dignity. This is a narrative that I want to bring towards you across the last 30 years in Nepal, how we travel through the journey from the disparity to the dignity, where we stand today from the different dimensions. At the very outset, I really want to mention that inequity can be understood, unleashed, explained using a different framework, various aspects. But I and my colleagues, co-authors, have chosen a different set today. Perhaps you have seen these numbers in different colors, different bars, different diagrams. But I'll be trying to explain it in our way, the way we think appropriate for this audience. Right, I deliberately choose the word disparity, debate, and put the dignity somewhere in the top, trying to understand. I have created a hypothesis here. Politics is the driver of inequity if the political choices are made wrong. But on the other hand, politics is the driver of equity if the choices are made in right directions. In this context, I'll be really fleshing out a bit more detail, looking at the policies, politics, and people in this equity journey. I strongly believe that political process, political forces, they form the government and they form the policies. And these policies basically guides the health system. The health and well-being of any citizen in the country is guided by the politics and policies. So we will be having a bit deeper look at how our policies are shaped, are unshaped towards equitable health gains and well-being in this country over the last 30 years. How the programs have been designed, implemented, and exercised enough with the highest impact, with the level of scalability and the high coverage, so we attain the journey from disparity to the dignity. हामी सबैले यो देखेको कुरा हो. My apology, this slide in Nepali. I've taken the manifesto of political parties, starting from 1985, 1990, then onwards, focusing on, and I've chosen deliberately 3 different elections to look at the commitment of the political party towards the nation, people, and the health and well-being. No big difference, my friend. All the political parties have demonstrated this commitment during the election that we will have health and well-being at the center. Great. Very important. That's why I strongly believe that politics shapes the country. This is the commitment from the various parties, including the traditional parties and the new parties in the election 2022, which talks largely, some of them, they talk the numbers, coverage 100%, bringing changes particularly among the people residing in rural area with the low health gains, bringing equity on forces. It's very important. I salute all the political parties for making this good commitment to the people, but the matters on its delivery. Looking at the policy and power, how the policies have shaped over the years, over the last 3 decades. My apology, this clumsy slide, but I had to present this to you. Looking at the National Health Policy in 1991, up to the JESHI Strategy 2023, which I consider is the latest document, as well as the Nepal Health Sector Strategic Plan, which has recently been endorsed by the government of Nepal, we all talk about equity in health sector. All the policies in different ways have addressed the equity concerns. And various milestones I have said, I and my co-authors have said, in order to unfold deeply how the policy shapes or de-shapes the equity in health sector. We'll be making it public in our paper later on, but this is the journey from disparity to dignity I wanted to really unfold here. How these policies have been translated in health systems towards more resilient, more inclusive, more result-oriented. So our health interventions are more specific, efficient, result-driven. And the health gains are up to the optimal towards samunnati, right? Just one thing I want to highlight throughout this presentation. One is the population parameter. Looking at the Madhesh, which holds the large set of the population, please bear in mind my subsequent slides, you need to visualize this population parameter. But here is the unequal status. I don't expect a homogeneous population across the provinces. There are the differences, understandable. But the Human Development Index, disparity in the Human Development Index is unacceptable. Looking at the per capita income, our political commitment to some extent has been translated towards the allocation of the resources for the health sector, where you see the percentage has increased, GDP per capita, rolling 3-year period, which I really appreciate. But has that brought the result that we actually wanted to gain? Is this enough, the trend that we have today? Looking at this, who spends most out-of-pocket expenditure, whether it's a catastrophe or that has contributed to impoverishment of the people. These slides, I just want to focus. Poorest are spending comparatively less compared to richest. Very good. It seems proper. But if you look at the impoverishment data, even the poor are spending less out-of-pocket expenditure in health, but their impoverishment is far higher than any other category. So this is the point I really wanted to note for you all. Distribution of health institutions. We looked at Madhesh, which comprises the highest population. But if you look at the Madhesh in second row, which has the very less number of public hospitals compared to the population, as well as the number of primary healthcare centers, number of health posts, and number of basic primary healthcare centers. Are we translating our political commitment towards the evidence and reality across it? That's the major question from this slide I really wanted to highlight. Our policies are good, but not necessarily our practice has onboarded the good policy in hand. The distribution of health facilities. Again, there are certain provinces with zero. I do not want to see in the next few years the zero in terms of the services. What made us not to be strategic in terms of distribution of our health facilities and human resources? If we know where we need to hit, perhaps we know by the evidence that we have today. Again, the human resources distribution across the provinces has not justifiable enough. Why this is happening? Why the higher concentration of human resources, including the speciality in certain provinces, not in across. There are problems translating policies into the real world. This is what the consideration we need to make. Perhaps you have seen these numbers several times, but I'm trying to really bring a different dimension here from the politics, policies, and power. Food insecurity in Nepal. Why the Karnali always has to top on the bar? It's very important. If you look at over the last 30 years of the development trajectory in Nepal, where the Karnali always sits in the very highly unsecured from the food security perspective. What are the policies, what we are taking enough to drive this curve? What our policy clearly mentions that all the population segment will have access within the 30-minute distance. This is what the national policy talks about us. But still, if you look at this, in rural area in particular, only the 65% of the population within the reach of 30 minutes. This clearly demonstrates the statistic distribution of the health facilities looking at the population and geography, which policy states very loud and clear, but in practice, this has not been translated. I totally understand there are limitations, but these limitations are within our merit to deliver effectively. Again, the distance from the perceived barriers, it has reduced compared to 2016 and 2022. People seem to be a bit more satisfied what has taken place in, compared to 2016 and 2022. However, there is a considerable perceived barrier still exists across, be that in rural or overall in urban area. I have no particular fit for this should be the TFR in this country. I'm not arguing on that. But looking at the 1996, where if you look at the no education and higher education quintile here group, it's 1996, 2.3 with the higher education and 5.1 to the no education. Education has a strong driver of inequity in this country, which was not understood yesterday, but it has been evident for a number of years. Also, looking at the caste and ethnicity, which seem to be a strong driver in this country for health inequity. The Muslim population with a 3.3 TFR rate, which puts in danger in many ways when there is a high TFR for the women and children. This is an interesting slide. Of course, all slides are interesting, I guess. But let me have a deep dive. I have looked at 1996 from 2022, almost 30 years, 28 years. If you look at the no education and higher education, and looking at the place of delivery in health facility, in 1996, 4.1 uneducated women were delivering at health facility, whereas almost 70% educated, higher educated women were delivering in health facility. The gap between these two was 66%. That 66% gap after 28 years still persists to the 40%. Have we done enough in terms of narrowing the gap between these groups? We are enjoying overall gains in health sector, but gain has to be equitable. If you really want to address the different segment of the population need in health, policies, programs, politics, all these three should be geared enough towards narrowing the gap between these two. Likewise, in child stunting, we had 46% difference between in 96, which has reduced to 25, but is still considerably high. नेपालीमा भन्न मन लाग्छ यो सहन योग्य farak होइन. We need to do something. Likewise, if you look at the neonatal mortality, considerable reduction in terms of from the 43% in 2001 to 2022, but still again. म लगभग 15 मिनट सकिन लागेको छ. I'll try to wrap within 5 minutes if I'm allowed extra. ANC visits. हामीले हेर्दाखेरि what we see here is the highest increase of 4 ANC plus visits if you compare from 2016 to 2023 from the DHS data. Karnali seemed to be the first unit in terms of increase. This is good evidence. However, if you look at how does it translate to the mortality, the impact indicator, it does not correlate very much. Likewise, if you look at these social determinants associated with the ANC dropout, with the multivariate regression analysis, again, education. No education seemed to be the higher dropout during ANC. The poorest are the higher dropout, as well as the province 1, province 2 seem to be Madhes were the higher dropout. So we have evidence which clearly demonstrate where we need to trigger our focus if we want to really reduce health inequity in Nepal. Again, institutional delivery. Highest percentage change occurred between 2016 to 2022, which is Karnali. But it has not translated to the mortality indicator, impact indicator. Still, there is a gap. This is only slide where the richest quintile has the highest burden, NCD. But the lowest quintile, the burden is still high. How do we reverse this? It is not that I want to see all the slide like this, but there is a trend. We have effective coverage of services for a certain segment of population, but not for all. Again, I don't want to go detail on this thing, but it's education, wealth quintile, and the provinces which are lagging behind is in maternal health service coverage indicator in terms of provinces 3 and 4. 2 is the Madhes province is the lowest one. This is interesting slide, another interesting slide, I would say. The far side of the slide, which compares from 2001 to 2030, where we need to go in terms of hitting our SDGs. The difference, the wealth quintile difference, highest wealth quintile and lowest wealth quintile, the difference in 2021 in terms of 2001 institutional delivery, which was around like 34%. But that difference increased. In 2006, it was 50%, and then 66%. And that dropped down to 55, and it still exists almost 32% difference between the quintile. Despite the fact that you will see the policy intervention across various timelines, whether or not these policies were pro-poor, these interventions were pro-poor in order to reduce the gaps within the quintile is the biggest question. If you look at the annual rate of reduction, richest quintile, if we don't do anything substantial now, richest quintile will continue to attain the SDG target. But we need to do more on the lowest wealth quintile, which requires almost 5% annual reduction in mortality, in terms of delivery, which is a toughest game. Tuberculosis, also, its poorest are the worst hit, and the highest age groups are the worst hit. Interestingly, we all thought that crisis like COVID has impact across the population segment, perhaps similar way. But if you look at the home delivery conducted during the time of crisis, better off people, richest people, while somehow navigating themselves toward the institution, although we had lockdown, but the poorest were the one basically forced to deliver at home, which increases the risk of mortality. Inequities in SBA-assisted deliveries. I've taken this graph. Among the poorest quintile, SBA delivery is more concentrated towards education. In this country, even if you are poor but highly educated within the poor segment, you are more likely to gain better off services. Your results are better. But if you are rich and uneducated, but still your chances of getting higher gains is higher. So there is a distribution and a strong association between education and health outcomes that's been delivered. Again, this slide, I only want to concentrate on the annual rate of reduction here in terms of achieving MDG across the various provinces. Can Lumbini reduce 11.3% maternal mortality ratio to attain by 2030? It's a substantial effort is needed. We are at the verge of competing the priorities, but this cannot be overlooked. Again, the highest when quintile achieved something 51 years before than the poorest quintile in this country, which comes to the neonatal mortality rate. If you look at the projection made by the author, it clearly demonstrates something achieved 51 years ago for the highest quintile will continue to achieve 51 years later. Again, local level mortality, I don't want to go detail, but there are certain districts where has high focus compared to other. Again, disparities in neonatal mortality, under 5 mortality. I want to focus on annual rate of reduction if we want to achieve the SDG, which requires neonatal mortality 6.8% reduction and the under 5 mortality 3.4% reduction. How we can achieve this? Again, similar current rate of reduction and annual rate of reduction. I really want to highlight here, mountains seem to be the toughest priority if we want to accelerate the reduction in terms of under 5 mortality as well as the neonatal mortality, which is far high compared to the hill and terai. We have geographic distribution which triggers the inequity. And the disparity in child mortality also, again, if you look at the wealth quintile, poorest, richest we have already achieved for the under 5. But if we want to really achieve within the poorest segment of the community, we need 9% annual rate of reduction, which is really, really a tough challenge for the health system to achieve. Again, quite a lot discussed in the last 2 days on the teenage pregnancy and childbearing. If you look at the percentage of women 15 to 19 who have begun the childbearing facility, looking at 1996 and 2006, the gain has not been changed over the years. We have similar in nutrition, disparities in inequities and child nutrition. Our policy says 100% coverage. If you look at the political manifesto, insurance will be covered in this country 100%. But this is what the reality data speaks. I love in the audience row some of the politicians to look at this slide more strongly and reflect and go back and talk how we can strengthen the coverage of the quality of health insurance. Absolutely undeniable, political commitments seem to be very progressive in nature towards the health and well-being of the people in this country. हाम्रा नीतिहरू विस्तारै प्रोग्रेसिभ प्रगतिशील भएको देखिन्छ। हाम्रो स्वास्थ्य सेवा प्रणाली विषमता छ, अनुकूलता कम हुँदा हुँदै पनि बढी भन्दा बढी स्वास्थ्यका अङ्कहरू ल्याउनेतिर प्रगतिशील देखिन्छ। यद्यपि हाम्रो स्वास्थ्यका उपलब्धिहरू समतामूलक छैनन्। हामीले लिएको दिशानिर्देश कार्यक्रमहरू जसले एउटा समतामूलक गेनतर्फ अगाडि बढेको देखिन्छ तर आउनुहोस् we have enough evidence, we have enough known to act better. To act like we need collective actions toward the geared of effort in order to reduce inequity. Ultimately, your political lens, the policies and the outcome and the health systems, यहाँहरूले धैर्यतापूर्वक सुनिदिनु भयो, सायद माया पनि गरिदिनु भयो होला। यहाँको लागि धन्यवाद। जदौ भन्न चाहन्छु। Thank you very much.